Good afternoon, everyone. Let's just give it another minute or two, and then we can begin with our agenda for today. And thank you for joining us. Okay, and then as we've done previously, as you're joining the call, if you would please, if you are an official working group member, would you please type your name into the chat as well as your affiliation for the purpose of our meeting minutes so we can capture attendance. Thank you for doing that while everyone is gathering. Okay, we do have quite a full agenda today, so I'm going to officially begin with just a very quick welcome. So thank you. It's been, I think, a month since we last all were together in one meeting to discuss our subgroup updates. Today, we're really excited. The sub-work groups have met an additional time, and I think we're able to go through our 3 options today and finish up with the proposals that were discussed in each of these working groups. So again, I really want to, first of all, express our gratitude and appreciation for the many contributions you all have given to this effort and the engagement you have. So we have a better product and better ability to really explore what our options are because of your investment in this. So I just want to state from the start, I know it's been a number of hours you all have put into this, and I just wanted to thank you again for doing that. So as we move into our meeting agenda today, I would love for you to just take a moment to take a look at the August 19th meeting minutes. If you would, I know Sharon has sent those out for you. Those of you who are on the working group, if you could just look through those, make sure you're in agreement with them. If there are any changes or amendments that need to be made, please indicate so. But when you're all ready, I will go ahead and take a motion for approval of the minutes after you have a moment to review. Sharon, do you want to display the minutes for a second? Would you mind just putting those on the screen for those who...
Jen, apologies, but I'm not able to display the minutes at the moment.
Oh, okay. No worries. Thanks, Sharon. Okay, if you've had a chance to review, I'll take a motion for approving them as presented. Let me see if I can get them here. Anyone?
I'll motion to approve.
Thank you. I think that was Adam. Sorry, I wasn't looking at my computer. I was actually
Yes,
trying to...
it was Adam.
Thanks, Adam. I recognized your voice. Thank you so much. We'll take you know what I'd like to do here for those of you who may not have received these. Let me go ahead and share just for a moment. So, and then let me just run through these here with others so they can take a minute. These are pretty brief meeting minutes, but and if there are any additional changes, please let us know. We'll take a second motion when you're ready.
I second it.
Okay. Thanks, Jake. All in favor?
Aye.
Aye.
Okay. Any opposed? If not, thank you so much. The meeting minutes have passed, so I'll go ahead and... Okay. As we move to our second agenda item, if we go back to the screen where our agenda is shared, we made a commitment to review any operational issues that had been identified and shared with the department so that we could research those and investigate those and help troubleshoot those. And we have not received any new updates on operational issues that have been ongoing or existing things that have been problematic for you. Are there any items that you'd like to share in the meeting here that we can help you with, that we can research or help resolve? Any problems you're having with either billing, claims payment? We certainly appreciate having you share those with us offline. But if you have anything you'd like to bring up in this meeting, I'd love to just hear that now so we can note it. But I haven't had anything reported since our last meeting. Okay, with that, we are moving right along, which is good. We are going to move into item number 3, which is our sub-work group updates. So we're going to start first with Eric Grant and presenting the team's efforts on the ACO managed care model.
Great, thanks, Jen. So as you'll recall, the subgroups were tasked to go ahead and meet and determine the must-have items that would be incorporated into the contracts if we did choose this model and incorporate the TAM population into the ACOs and UMIC plans. And so we had a very robust discussion and talked about several requirements. Also, what would potential outcome measures be for some of these requirements? So the first one I want to touch on that came up in the group was to specify a ratio of care managers to members. In the discussion around that, there were some concerns about the structure of each of the ACOs and how it might need to be a little bit flexible because each of the ACOs accomplish care management in a different approach. As far as outcome measures we talked about for this one would be measuring the number of TAM members who stay outside of the criminal justice system, or are they also staying in treatment? So those were some of the items that we discussed around that requirement. The next one we talked about was expanding the essential provider list and also higher level reimbursement for those essential providers. And for those two, we didn't have any specific measures that we thought of to attach to that. There was some discussion about risk dimensioning on the top 1 to 5% of the population. And basically to ensure that the most medically complex people's needs were being met. Potential measure for that was what the ACOs were doing to reach out to those members who are newly eligible. We talked about PA requests and reviews and having consistency across all of the plans regarding prior authorization reviews. Potential measure for that would be turnaround times on the PAs and the outcome. We also talked about aligning incentives or providers and payers with the contracts. Example would be transitions, collaborations, and social determinants. Really didn't get into discussion of any measures for that. We also talked about timely payment of claims and how we could potentially write that into the contract. And again, the measure for that would be fairly simple, just how quickly the claims are being paid. And finalized, we talked about formalizing the process of how providers can utilize the Division of Integrated Healthcare, specifically the Office of Managed Healthcare, to help resolve issues between the providers and the ACOs. And so that's basically the discussion we had. Any questions?
Hey, Eric, I'm sorry, it took me a minute to go. Pat Fleming from USAID. Hey, one of the things around the payments, an idea that came up in other discussion is a subcap or a prepayment to providers.
Okay.
Did you guys talk about that at all?
We didn't in our group, but we can definitely add it to the list.
Yeah, I think it may be in some other list. Maybe Brent's got it on his or somebody else, but I think that's really an important thing. I mean, you know, the relationship between the providers and the payers is a long-term relationship, and payment first and adjudication later, I think is a good faith effort at resolving things. And so I whatever group's going to deal with it, I want that to be on the discussion list.
Okay, I've added it. Jen, if you are you displaying, Jen? Yeah, scroll down.
I'm displaying. Sorry, Eric. I was
No, you're good.
yeah,
So
I wanted to
added
just
the
have the
calculation.
notes here that Eric was referring to from the working group up for visibility. And I should have framed this when we started. Our goal today is to present these to you, have really robust discussion in the areas that are presented, because our goal is to have a recommendation, right? What is the working group's recommendation of which model, right? And which region, all those things as needed. So we really would, welcome your active engagement and feedback in this.
Emma.
Yeah, I'm wondering, Eric, if we want to broaden that. I mean, subcapitation is one method of reimbursement, but I think just about in every group, the discussion has come up about just paying based on episodes of care versus individual claims. And so I think, Pat, I think what you're getting at is just looking at this upfront payment or a payment in a way that is less administratively burdensome for providers as well.
Okay, that's helpful. That's a good clarification. I was thinking of in terms, Pat, to be honest, of a per member per month. So no, that's helpful to understand that.
Is there any other feedback on this or the information Eric presented from the working group? I don't know if the sub-working group has any additional comment they'd like to provide. Emma?
Sorry, Jen, I always have something I want to add. So the other thing with regards to care management, besides looking at some sort of ratio of care managers to individuals, we also talked about the fact that if the individual had a care manager already established with their provider, that the division wouldn't disrupt that relationship, but the care manager for the plan would be expected to proactively coordinate with that care manager and others, just to make sure the individual is getting what they need in order to be successful. And if there is no care manager, then the plan care manager essentially would be the primary manager. But the intent is to have a lot of coordination between the plans and what the providers or other community-based organizations are already providing to these individuals.
Jen, Pat Fleming again. Can I ask a question? The TAM population is a very difficult population, very chronic health concerns, behavioral health concerns especially, sometimes not very compliant with treatment. So do we have any willing provider provision in our waiver or something like that, or can we limit the providers who are serving these people to providers that we know can really work with this population? I'm not trying to limit the provider base out there, but some providers are going to be very, very good at working with this population. Some may not have any experience and may be gamed, to be blunt about it, by the consumers. So what's the rules, the CMS rules on this, and can we limit the number of providers that we have out there?
So I'm going to try to address this one. Emma, please jump in if I get something wrong. But the way it works is under a fee-for-service model, which we're currently under, Medicaid has to engage with any willing provider who's enrolled. So when it moves to managed care, it falls under a 1915B waiver, which basically limits the member to the network of providers established by that accountable, in our case, accountable care organization or UMIC plan. And so it'd be the responsibilities of the ACOs and the UMICs to come up with that network of providers and to craft their panel how they see fit.
It can also be done via the 1115.
That's correct.
So either way, but it does require a waiver of some sort to limit the providers.
But I do like what you're saying, Pat, around the adherence issues with this population. And is there a way to craft maybe an outcome measure or contractual requirement that would help support this in this type of model, right? So I know you're thinking provider focused, but are there other ways to be able to get that what you're looking at here by creating some sort of contractual language that would help achieve metrics of adherence that you're thinking about? Like whether that's, proactively engaging in follow-up visits or med adherence measures, like you mentioned before, around, being adherent to different, whether that's their mental health meds or their substance use treatment program, that type of thing. I don't know how you might want to do that based on your comments, but.
Well, the other thing I'm thinking, Jen, is that it also for the consumer has to have choice. I understand that, but for this population, sometimes choice isn't the healthiest thing for them to have. So, I want to give them the option of going to a good provider, but I think if we've got a really good provider system and we know that people are going to be delivering quality care and we have good partnership with them, then I think that maybe we can force some individuals to stay inside of a treatment agency when they may not want to, because treatment is getting really hard for them. They're having to face some things they haven't had to face in the past. So, kind of both ways on that.
Jeannie.
So you'll have to forgive me. I'm not a clinician. So this comes from the financial side and just years of experience. So my question is, have you, when you're considering this model, have you considered anything different in the rural areas?
So we actually talked about that in our first meeting and talked about where geographically we would want to do this. Sorry. Okay. And our discussion was kind of focused around the 4 Wasatch Front counties to start there. There was a discussion to propose to add in Morgan, Summit, and Tooele eventually, but that was the initial discussion, was just to focus on those 4 counties initially. So Salt Lake, Utah, Davis, and Weber.
Okay. I would just like to tell you something that's happening, and it might just kind of give you some ideas on when you're having these discussions. So we send a lot of people to residential treatment in our area, and I represent Four Corners finance piece. And what's happening is they get to the residential facility, we authorize payment and everything, it's great. And then automatically they switch the client to TAM. The concern I'm having, and I'm trying to wrap my head around it, because there's a lot of reason to move somebody to TAM. They get all these benefits. They can stay on for a year, But the issue is that these folks really need that warm handoff and managed care when they get home. And we lose that when that happens. And so we're heavily invested in the client. Sometimes they're in even drug court programs and programs that are managed by the behavioral health entity. And then we kind of lose them. And so I guess think about that. I tend to think of TAM folks as equal to chronic mental health clients that need managed care and need that. And they really need to come home to localized managed care with partners. And I do think integrated care is awesome. And we need to be thinking that way. But at the same time, they really need that community involvement.
Yep. Emma's raised her hand, and Emma, I think I know what you're going to say, but go ahead. I'll let you go.
Well, you can go ahead and see if you can read my mind.
Yeah, let's see if I can. So Jeannie, within the program right now, not excluding the TAM population because they're not within managed care, in the rural areas, members do have the option to choose to enroll in one of those plans. And so if we incorporated TAM in, I imagine the same would be true there, that they would have the option. Apparently I didn't get it right.
Well, what I was going to suggest is with the adult expansion population, I think one of the things that we talked about is trying to create some continuity of care for targeted adult Medicaid, because it's only going to take, I mean, it's all dependent on their income, right? If they have zero income, they're TAM. If they don't have zero income, which many of them are required to be employed, so that, you know, eliminates their zero income, they become adult expansion. And in the rural areas, yes, they do have the option to enroll in an ACO, but they are enrolled with the PMHP, which is essentially the local authority. So one of the things that might be good to consider is should we automatically enroll the targeted adult Medicaid members in their prepaid mental health plan, which is run by the local authorities, like we do adult expansion members. And Jeannie, I think that's probably what you're getting at, is again, just to have that continuity of care, because I agree, it only takes a small shift in income or an error on the part of the eligibility worker to have them bouncing back and forth between being required to be enrolled with you and being just free to pick their own provider.
Thank you.
And Jeannie, as we're typing here, if we are not capturing what you kind of were trying to articulate in our notes, could you please, so I use the word interventions, but really you were talking about models that support continuity or transitions, and I think Eric put some notes next to it. Is that what you were thinking? Anything more you want to add?
Yes, and I like your words better than mine, so thanks.
Yeah, thanks for sharing your thoughts.
Okay, any other suggestions, thoughts? Oh, Adam.
Yeah, I just wanted to, I think that there were a couple of things that I just wanted to clarify. So there's been concern about utilization management and those shifting over time and not having a provider voice in those shifts and having inconsistencies across all different plans. So having something, a forum for that to occur, not in a vacuum. I think the other thing that I would add to Emma's and Pat's point is, and one of our fears is, one of the main levers of cost control is rationing care. And I think this provides an opportunity to do payment reform where we can do either subcapitation or episodic payments for care, where we can actually reduce costs based on the correct dosage of treatment, rather than trying to manage costs by keeping utilization down. So I just wanted to make sure that got reflected.
Yeah, we did. So Jen, could you scroll up or right there under the subcapitation? So the paying by episode of care rather than individual claims. And then I think Jen has just added consistent policy across plans.
Yeah, yes. And I guess also adding that policies, if they're going to be changed, that would be a collaborative discussion between providers and the payers.
Okay.
And the state. I mean, the state needs to be
Yes.
there at the table.
Yeah, obviously, yes.
That was the original concept of part of the original concept of the clinical collaboration committee around the integrated plans, but that's never really taken flight the way we had hoped. But that is a form that could be expanded for that purpose, which includes providers, the ACOs as well as the state.
Adam, thanks for bringing that up as a point. I think it's a really good one.
Thanks, Adam. Sean.
Yeah, I thank you, Jennifer, for putting an exclamation point on that. I only wanted to just add another exclamation point about how incredibly important that point is, that Adam raises, and that Emma just Emma mentioned. Just extraordinarily important because of the chronicity of the population that we're talking about. Thank you.
Great. Thanks, Sean. All right. Any other comments?
I'm just kind of scrolling through these one last time for your review before we move to our next sub-working group. Okay, thank you, Eric, for your presentation, and thanks everyone for contributing to that. And I don't remember who's up next on the agenda. Is it Brian? Are you up next? Adam.
Sorry, I just wanted to add one more thing,
Yep.
because I think it's been across all of the discussions, but making sure that we have a plan in place and we're prepared for whatever we're going to do, that we're not rushing to get something done and we haven't thought everything through, that we do it intentionally and effectively.
Mm-hmm. Thank you, Adam. And that, I think, recommendation would go across any of these, the final path, right? Is that it's very thoughtful in its development, design, and then implementation, right?
Yes, correct.
Yeah, thank you. Okay, thanks everyone. And certainly we can go back if something comes to mind that you say, oh, I wanted to add this to the notes on the ACO managed care model. We can certainly go back and visit that, but we'll move on to our next sub-work group update with Brian. If you would please present the fee-for-service and case management, unless I'm happy to present it as well. So
I will present you.
Thank you.
One moment, I'll bring it up. All right, thanks everyone. So yeah, similar themes, similar concepts tackled in this sub-work group to what Eric just presented, focusing on a fee-for-service plus case management model. At the beginning of our meeting, I just asked if there were any updates, concerns, feedback for the sub-work group members to share with the broader work group, and I'll run through those real quick. So first of all, there was just some general concern about the timeline, and it sounds like Adam just kind of expressed a similar sentiment a moment ago about, we are keeping that July 2023 date in mind, and that's approaching just with everything else that's going on, PHE unwinding, PRISM, the new eligibility rules, which many people may be aware of, is a proposed rule right now. RFP timelines, waiver amendments, the requirement to get appropriation. So it's a little bit of just concern that is shared that I think all of us can appreciate. And it's consistent across all options. Just make sure, are we collectively prepared for what we need to do? And they all do require some amount of pre-planning ahead of time. So, and the key is making sure that members do not have disruption in their access to care. I think that's all of our priority number one. Next, we transitioned to the two components that Eric mentioned, which are what contractual requirements should we consider with this model? And then the second item is what performance measures should we keep in mind? So contractual requirements, this sub-work group was focusing on fee-for-service plus case management. So, contractual requirements, we tried to focus on if we executed a case management contract, for example, what provisions would we see in that? What would we recommend in that realm? So it's not quite the ACO contract requirements, but case management view primarily. So first of all, pointing out that the ratio, so the ratio of 1 to 35 had been brought up before by one of our ACOs. That ratio is viewed to be sufficient even in a situation where TAM members are highly engaged in their care. So the 130 to 35 is kind of seen as the upper limit. That, at least our sub-work group recommended that. But we do need to recommend something like a stratification algorithm where lower level TAM members may not need that same level of 35 to 1 case management. It is, for the work group members, they did really like this restriction program as a guideline, the definition of it laid out in contract, and recommended in-depth reporting alongside whatever case management contract is envisioned here, which would include outcome measures as well. We went back, we focused again, this was a topic before, but how feasible is it to have case managers in low enrollment counties? One of our counties in particular has roughly 12 members on TAM. So it would not allow for a case manager in every county. They would have to span larger geographic areas and employ technology solutions like telehealth or some other technology solution. We discussed an interplay between members receiving services in agency and out of agency. I think this was mentioned just in Eric's updates that clients may already be engaged in case management at a particular agency, and our goal is not to just disrupt that relationship. Our goal is not to substitute that, but support that with other resources if they already have a successful case manager in place. And then finally, one of the recommendations was Arizona's system as a template for such a system. So as far as that was kind of the thought process. Here are the recommendations, and apologies if my dog barking in the background is being picked up on the microphone, but okay, so what was prioritized kind of as the number one recommendation to the group is that we need to have statewide standards. We can't have a fractured system where in some counties we have certain requirements for case management and certain expectations, and then in other counties we have different. So that was priority number one. This goes back to what I just mentioned. If a member is already attached to a provider, that provider should be the primary case management provider. So we don't want to disrupt that. We should be providing coordination, but members should have one contact. It's we don't want to say, you know, you have 3 different case managers across 3 different programs. That's not our intent. And the case manager would need to be connected to available resources. It was pointed out that not all providers are capable of providing that, so we need to have a flexible system where, depending on the provider, whether they do have a robust case management offering, that either the department or a contractor is able to provide that in lieu of the provider. And there was the suggestion to look at the JJS hub model as kind of an air traffic control for care coordination as a potential model. Next, it was brought up the interdisciplinary care team model and this idea to have all parties come together monthly or at least quarterly to make sure care is coordinated for members. It's important that member drives and identifies their care team, but they are the ones that choose who is on their care team. And then lastly, or maybe not lastly, but a court liaison was spoken about, reducing unwelcome criminal justice outcomes for their members, and someone who is able to liaise with the courts. And then I think I spoke about these technology limitations already, but just, there's some travel ability, but substituting with technology resources where available. Okay, so moving on to performance measures. So outcomes reporting would have to be a necessary step for these contracts. Goals based on the need for each member, individualized, and track the member to see when and if the goals are met. So we spoke about individual goals being met as an outcome, HEDIS measures as supportive measures that we're all very familiar with and support. Some of them are laid out here as part of our core set reporting. Social determinants, which we have laid out, the important ones for work group members are housing, food security, attachment to primary care, positive trajectory with court mandates, employment status, earning a living wage, and family reunification. And then finally, PAM, or patient activation, was brought up as an excellent evidence-based tool, although there is an expense, but that was a recommendation from the sub-work group. Filling in a couple of blanks that I missed along the way, but there was also the idea that the question of whether emergency services reduction is a valuable measure. It is, there were some concerns about that because especially in rural areas, it may be that emergency department is a necessary access point for some members, especially for certain times of days or weekends when access to care is limited. So there was a little bit of pushback as to like prioritizing ED service reduction as like one of the primary measures in this process. And then kind of an interesting thought that I wanted to present to the group that got brought up is one of the overall success is that a member no longer needs TAM. If we're overall successful, the TAM member may move to the marketplace, may get private coverage, and there is some disruption that goes along with that. They may lose their dental care. We need to be looking at what's next and prepare members for that eventual. What is eventually a success is they get more independence, but there is a loss of benefits along the way. So making sure they get appropriate coordination in that process. So those are the thoughts of our sub-work group, and I welcome any questions. Yeah, Pat.
Brian, so when you mentioned that one county or one area only has 12 TAM enrollees, that's not that isn't one of the 4 Wasatch Front counties.
Most certainly not. Yes, that's San Juan. So okay. Yeah, no, there's
that makes sense. The other thing is, what's the interplay with enrollment and with the Department of Workforce Services? So it seems to me in a lot of cases, the reason I'm picking up on that is the idea of the court liaison is a really good idea, because most of the TAM people are going to have APMP, Department of Corrections, or court involvement. I think that's really a good thing. But making sure we do an aggressive enrollment push for TAM, I think, is really, really important, because it's such a great benefit. And I'm just wondering, is there any thought, any discussion on that at all?
Are you, so to clarify your question, enrolling first time or keeping them enrolled? Is that, or both, are those?
So I'm thinking first time enrollment, at a court level, first time enrollment at county jail. How's that outreach happening? So we're making sure that we're getting all of the people eligible for TAM to get enrolled in TAM.
Yeah,
or not, but I think it's important.
Pat, I think if I can step in, Brian, these are actually some discussions we're having right now with the jails on how we can improve this communication, Pat. And I think it's one of the items we should actually really put on this list as an objective, and it should be for all three of these lists for the models that we have. As you know, there had been talks around a database, right, and sharing that. But in the interim, there's also opportunities just to work collectively with them on sharing that information, so we can have more timely updates, right, with disposition. So, but we actually just met with the Department of Corrections this week, and that was an item that was brought up in that setting. So we'll make sure to keep following through with that. Emma, you may want to comment on the federal.
I think you're spot on that. I think the other question, though, and Pat, correct me if I'm going on the wrong track, is when we first established TAM, we had a very specific, unique process for providers to communicate with workforce services about the fact that they had an individual that looked like they qualified for TAM. And I think even before I left my previous role, Workforce Services had made a recommendation to do away with that process, assuring everyone that, there would still be people who would specialize with regards in their organization with regards to the target adult Medicaid population. I don't know. I'm sure that's all gotten lost in the PHE and everything else, but it is something that we may want to look at to make sure that people aren't slipping through the cracks. Even after they get referred over to Workforce Services, are they clearly being identified as being someone who is potentially TAM eligible and that kind of thing. So I think it's a good one to look at again, just in terms of what Workforce Services is doing.
I agree with you 100%, Emma. We can't let that off. We can't let that go yet. And just to be blunt, things I hear from consumers is it's very difficult to work with Workforce Services. And so I think having an intermediary there is incredibly important.
So Jen or Brian, may I offer a comment, please? Jen, when you said you're interfaced with corrections, so that's the state prisoners, what about the county jail?
The meeting that we had this week, representative, was just with the corrections.
Okay. So,
and just for context, it was on a different topic, but just this item was brought up around the Medicaid, involvement.
Pre-COVID, we had it set up, and maybe even partway through COVID. So I had a meeting with DWS, Odyssey House, and some others. Odyssey runs CATS in the county jail. And the intent was to get them kind of pre-enrolled, or at least an application ready. So upon their release from Salt Lake County Jail, they could get their Medicaid activated quite quickly. I think that is gone. When I went to the jail's got this new reentry resource room, and all the inmates, because Salt Lake County Jail has a lot of inmates. They have 2,000. They're a big deal, particularly in Salt Lake County. And when these inmates are released, they go through this resource center, and they have somebody, a Medicaid person, that can help them enroll. They refer them to UHPP, but they say it takes 1 to 2 weeks, to get them enrolled. And UHPP saying, well, in fairness, we can't prioritize them. So I I don't know, Jen, if your team wants to do this or if you want me to organize it. I think we need to have a meeting with DWS. I think we've lost some of the seamlessness that we had. And I know everybody's busy, but I think we need to try to re-engage and see how we can improve that process. And then quickly, since I have so much talent online here, what's the retro ability? Somebody gets out of jail, they sign up for Medicaid. How far back do they go for claims?
It can go back 90 days from the date of application.
Okay.
So, yeah.
All right. So that's good, but still that delay. Anyway, I won't belabor it. And Jen, I don't know if you want to facilitate that or if you want me to contact DWS. Do you have communication with them?
We haven't talked specifically about this with DWS in some time is my understanding. So I think it'd be fine if you want to coordinate that. That would be great.
All right. I will do that and
Thank you.
we'll invite whoever wants to participate in that. Thank you.
Representative, if I could just add to, in addition to the initial application, I think one of the pieces that we're missing for continuity for this population is knowing when they're coming in and out. You know, that's it. I believe DWS actually gets a report from the Department of Corrections on the prison, but there isn't a similar exchange of data with the county jails. And a couple of years ago, statute was changed to require that when someone goes back into jail, that their eligibility is not terminated, but it's just suspended. And of course, when they come out, it can just, in theory, seamlessly be reactivated. But in reality, that's not working as smoothly as it could, because people go into jail, they don't tell anybody. Workforce Services keeps them open. We don't know when they're coming back out, you know. So I think that's another part of that discussion if we really want this to work well.
Thank you. Jen, is it okay if I involve Emma in that, or do you want me to do somebody else?
Sure. No, that's great. Thank you.
Okay. And let me just say this. I'll contact DWS. If you want to be a part of that meeting, just shoot me an email. I think most of you have my email. Just let me know if you want to be a part of that. Thank you. Thanks.
Sorry, and I forget the name. So it shows up as House of Hope, but it's Lisa.
Sorry,
is that
it's
right?
Lisa. I haven't been able to change
Yeah.
it. I apologize. I just wanted to add on here too that I have a dream that someday, after all the work we do to get people on TAM, it's such a great program, that there would be some way to keep them on TAM rather than having them move off if they get their kids, or it really puts, being here in the trenches, I see the conundrum that it puts them under to move from expansion to TAM, then getting their kids or having another circumstance happen where then they end up where they can lose their Medicaid because of work, or they lose their dental, or just the confusion. And I would love to see like a pilot where they could get on a Medicaid and stay there get on TAM and stay there for 6 months. Which I think was the intention of TAM to begin with, that they stay for a year, but we just don't see that happening.
Okay, excuse me. I got to jump in on this. So they're not getting a year? What?
They get a year if nothing changes with them, but we have clients that even though they're still in court, even though they still meet the criteria, there are things that then move them from TAM to another program. And so the clients that I have seldom come in on TAM and stay on TAM the whole time. And so technically somebody gets their kids back and then they start working, they make too much money, they get kicked off of Medicaid because they moved to legacy Medicaid with their kids. And so I think that's a bigger population than we know. And again, when you're moving between 3 different Medicaids in 6 months, it makes it hard to maintain those relationships.
So Lisa, that actually, well, I don't know if Jen, that's something you're aware of. That doesn't seem like it's my understanding of movement. And so, but maybe we can double check. I thought they remained on TAM.
No, we see it every week. People go off TAM. They can't stay on TAM when they have their kids.
Can't they stay on TAM and their kids go on legacy?
No, Adam, do you want to speak to that? Because we all see this every week. So,
Sure. It's particularly in the pregnant and parenting programs that you'll see somebody come in on TAM, and then we reunify the children with the parent, and then they automatically switch over to legacy, and then at that point, if they get a job, they would potentially get kicked off Medicaid in its entirety in the middle of treatment. Also, the other thing to think about, because they might have come in on TAM, they might have started to get some major dental work done, and if they switch over to legacy Medicaid, the dental benefit goes away. So they might be, mid-major dental work and not be able to continue.
I think your comments around what you're observing with changes in eligibility are things that we should research. And if we could get the names of the individuals who you've taken care of, who are affected by this, it would be helpful for us to research this and work with you offline, if you wouldn't mind. And Adam, your point about dental care, honestly, that's another item we know as well. But with the shifting of plans, that's something we need to look into, right? So could you let us know, if you would, Lisa or Adam, who some of these individuals are, so we can look at their eligibility pathway and follow that, and then we can work together to just communicate about that offline.
Sure, no problem.
Yeah, thank you for bringing it up.
Okay. Seeing no other hands, I think that concludes my subgroup presentation. Thanks.
Thank you, Brian. And thanks to everyone who worked on that sub-working group as well, and for your really thoughtful feedback that you gave for that part. We're now going to transition to our last model that we were looking at, and this is actually an RFI, so it's not a specific model. But Brent, if you would go ahead and present what your sub-working group evaluated and the recommendations they gave in this model, if you go ahead and do that.
Thanks, Jen. Looking for permission to, okay, got it. Let's see, I'm going to share a document with you that I put together. Okay, can people see that? This is the document that I'm working for. So our subcommittee was asked to explore the possibility of the state issuing an RFI to identify potential innovations or integrated approaches that would improve the quality of care, ensure access, and provide a better member experience for the TAM population. And then we were then asked to report back to the larger group, and this is that report. There are many different states, a lot of states that are doing work in this area. There's a lot of different models of integration that we discussed. And so really our question was, could the state use an RFI to identify potential innovations that would help us meet our goals? After we met twice as a group, and it's the consensus opinion of this group that issuing a broad RFI is not the right direction to go at this time. We did identify that using an RFI to identify solutions to very specific problems as we go forward with an integrated approach could be of potential assistance. The rationale that the group came up with for that recommendation is that we're somewhat constrained by regulatory limitations from CMS about what we could or could not do within TAM at this time. There's the time that it would take to do an RFI, the administrative burden, the complexity, and that implementation of an identified innovation would actually probably take the same type of meetings and efforts that we're all currently engaged in. There was also a recognition that we have tremendous expertise here in Utah that we can draw on to meet our goals, and that the administrative landscape here in Utah is unique and requires specific knowledge to implement those innovations. So as we had that discussion, we then pivoted and started looking at our objectives and the specific problems that we could start to use an RFI or we think need to be part of any plan. I wanted to make sure that we drew out some feedback from these this sub work group also. So in terms of our objectives, we identified that an integrated approach that improves the quality of care, ensures access, and provides a holistic member experience that's cost effective is important. We identified the need in whatever we go forward with to have a smooth transition. This is a population that is pretty vulnerable, and those of us who have been through significant changes with Medicaid know how disruptive it can be for members, and so we need to be thoughtful about that. The concept of ensuring access and provider choice and whatever we move forward with was important to us. And then there was also an identification that plans and providers need flexibility to implement strategies, and it's okay for plans and providers to be implementing unique strategies, and that might, in the long run, benefit us all. Chad Westover brought in our first meeting this concept of, okay, if we're going to use an RFI, what is the problem that we're going to try and address? And we had lengthy and I think robust discussions about some of the problems that we see with the TAM population and the TAM benefit right now. And it's very similar to what Eric and Brian identified, what we've discussed in this larger group before. I think the work group identified a need for better care coordination, care management. Providers and slow payment was a problem that they were concerned about, and wanting to make sure that if we do transition that we address that issue. Health equity was brought to the table by this sub-work group. We know that there are populations that have been historically marginalized and may not access services at the same rate as other populations, and that's something we think needed to be addressed. Like I said, access and choice. And then this concept of resolution of payment disputes, and we'll talk a little bit more about this when we go over contractual issues. Because this work group was not dealing with a specific proposal in mind, I would say that the contract terms that we identified maybe occurred at a higher level. And so we're thinking about, and whatever we go forward, we want to make sure that these issues are addressed in contract and that we're accountable in these areas. So the concept of timely payment was an issue that we discussed, and some of the suggestions, recommendations that were brought forward were prepayment models or subcaps or payments within a specific time frame with reconciliation, which seemed to, well, there was sort of consensus that was important. The identification, so if we went forward with an ACO or an MCO solution, the identification of essential providers and an enhanced rate for essential providers was critical. We do that in some of our other plans and strategies. We think that's very important here. Like we discussed earlier today, there are providers that are absolutely critical to providing good care to this population, and we need to make sure they stay at the table, and that system that's been built over time is not disrupted to the point where we have people who are most chronic, most vulnerable, who are left without an adequate provider network. We had a discussion about the reinvestment of savings or Medicaid reserves, making sure that those stayed within behavioral health care, and that if there are Medicaid savings or reserves, that they're used to expand and build the system out. And we think that should be addressed in contract. To address the issue of disruption, we identified the need to be very thoughtful in identifying our transition requirements. So if we're going to switch from one plan to another, let's identify the time frame. Let's identify how that transition is really going to occur, and let's not try and do it, in a day or a week. We I think I have encouraging reinvestment of savings on this twice. And then we had a discussion about the creation of a third-party intermediary who could help resolve payment disputes between providers and ACOs. And there was some discussion about that. Right now that's a role that the counties play, at least in Salt Lake County. It may be something, I believe that's something the state could do. There was thinking on the call that maybe that's not a role that the state could do, but we felt like it was important to make sure that that providers had some support and assistance in working that through. So those were the issues, and we had a lot of discussion. I hope I summarized our discussion thoughtfully and carefully. So, and that's really what I wanted to present. So if there are committee members or others who want to build on any of these issues, we can have that discussion.
Brent, you have some hands raised here. I think.
Oh,
Dr.
okay.
First. Sorry about that. That's fine. Go ahead, Dr. Whittle.
Transition from presenting to facilitating. So, Pat, I think you're muted, Pat.
Yeah, let Dr. Whittle go first. He had his hand up first. Brett.
Okay, Dr. Whittle.
Yeah, I was first in the door on this one. Fantastic job summarizing. That's a great summary. It really helps conceptualize all that good discussion. And would you do me a favor? Are you able to scroll to the more northern part of this doc? Yeah, right there. So I think this is implicit, but looking at where we're going with the discussion, we might want to add this. Implicit to a lot of that is the element of data sharing. In looking what organizations are doing in terms of standing up these objectives, the first step is usually deciding what data we have access to, and then deciding what groups we share that data within, so that we can derive from the data the key metrics that we'll follow and establish our goals off of those, so we can link all the elements of the chain into one cohesive unit. So if it is possible to maybe just add one of the objectives being to clarify what data can be shared, and to establish that understanding that we would be data sharing to help us all start from the same point and measure our success. And then so yeah, thank you. I appreciate that. And then at the very bottom of the document, I think that last bullet point, the creation of a third party, I think the idea was probably a little more broad than just managing payment disputes. I think it was really around coordinating the whole thing. So, for example, if on the data sharing, if we're going to be data sharing, the data sharing really would be streamlined if there's an immediate group that can be the clearinghouse of the data, the holder of the goals, and support the entire discussion and moving forward. So we might consider looking at that third party as a data repository, a holder of the goals, the measurement of the goals, maybe setting up those goalposts and helping align us to a true north that we've all agreed upon. So we might be able to expand that role into something that's supportive of the strategy as a whole.
Okay, and this was an issue that we thought, Jen, that if we were to create a third-party intermediary, that may be a specific issue where an RFI could be helpful if we agreed to go in that direction. So we did have that discussion also. So Pat.
Yeah, Brent, thanks. Yeah, good summation of our discussion. I just wanted to sort of punctuate, again, and I don't want to sound like a broken record, but my experience in Salt Lake County is this third party, the role the county plays is really, really important as an intermediary between the providers and Optum Health. Optum is managing, the Medicaid product for Salt Lake County, and Tim Whalen has to get involved, probably on a weekly basis with this, and we feel like it's really important. I am of the mind that we need this. I think it does need to be outside of the state agency, though. Ultimately, the state agency is going to be, have the final say on things. But I think if we can have a third party resolve a lot of these things, like Dr. Whittles mentioned, I think it really will keep a lot of things out of your hair at the state level. The other thing I wanted to punctuate a little bit on this is the reinvestment of savings. We don't want anybody to get rich on TAM. We want the savings reinvested in the expansion of services. It's incredibly important. And again, another broken record. That's what happens in Salt Lake County. And that's allowed the build out of more services for people. So I think that's a contractual thing the state would have to have with the ACOs, the MCOs, whoever's going to wind up managing this, that we allow a profit corridor, but it cannot be excessive. And those savings then get plowed back into expansion of services for the population.
Yeah, thanks, Pat. That's why I put that one on the list twice, I guess. Nina, I see your hand is up.
Yes, can you hear me okay?
Yep.
Great. I think it was very, very helpful the way that this played out to kind of drill down into some of the details of the very specifics that we've been talking about. And one of the ideas that I had wanted to propose, and I apologize, this is a little out of order. I had submitted it right at the end of our last subgroup meeting, and I kind of ran out of time. We didn't get a chance to see it or talk about it. But one of the things that's been in the back of my mind is that perhaps, and it could be I just don't understand how things work, but perhaps we're missing an opportunity of value in having the ACOs come to the table with their suggestions and have a proposal for integrating the things that we have come to the table with thus far, and also things that they have found to work on their side. It sounds like we're kind of recreating, and certainly it's very, very valuable what we're doing in terms of shaping this, but they also have an enormous amount of resources and talent and experience on their end. And from day one, I would love to see a proposal from their end on what have they seen be successful? How do they plan to meet these needs? They know what's at stake. They know the members, they know the money. They're saying, I want $250 million to manage, and I want to see what their thoughts are on how they might do that, given some of the discussions, because they've been involved. By this point, I think they pretty well know some of our thoughts. And I think if we had their framework, it might help us fit in some of the details that we have instead of building it from the bottom up. And I'm just kind of wondering if they're the ones that want this business. In any other business, you'd say, great, you want the contract? Then bring something to the table for us to look at. That none of them, to my knowledge, have done that. And they have VPs of government contracting, VPs of quality. Would it be a reasonable request to say, you bring us something to look at as well and get them started on their end? Is that an odd idea?
No, it's not an odd idea. And I think that might be a next step. I'll leave that to Jen, but I think that one of the things that I think we discussed in our group is this concept of an RFI, and when you take an idea from another state and bring it here, we have partnerships here, we have relationships, we have kind of a unique administrative landscape. TAM itself is something that most states don't have. And so translation has to occur first when you bring something here. And so that idea of having the ACOs bring a proposal, I think, is consistent with our thinking, at least from my work group's perspective.
Okay.
Scott?
Yeah, thank you. And I appreciate you making that point. And I just want to, I think we've all had plenty of time to kind of digest all of this over some time now. And I think this, Pat, tell me what you think. I mean, I kind of believe that the ACOs to some extent outsourced this process to Salt Lake County and to some extent the other ACOs, because if you look at the product we're offering Medicaid as a whole, it's largely the process that Salt Lake County supported building some time ago, and to some extent they attempt to duplicate elements of that in other geographies. But it may be that the real partner we have in this space is on some level Salt Lake County, because that's where the real staff, the real riches, the real work on this has taken place over the last number of years. So it may be that it's a kind of an ACO is giving a nod to Salt Lake County, and then the system as a whole, the system of care, kind of looking to Salt Lake County for the elements that have been put in place, and making sure the elements that have been put in place are respected and to some extent preserved and improved, continue to mature. So I don't know if other people would agree with me on my reading of the landscape, but to a large extent, I think, Salt Lake County has borne a great deal of that responsibility.
Yes, Dr. Little, I agree with you on that. I mean, I went so far as even to propose to Tim Whalen a couple of other ideas on this, and of course he was really nervous and worried about it. But I think you're right. I think the framework that we've set up is because Salt Lake County is a network model already. It's not a direct service model, and it's a contracted network model with a manager in the center of it. So in a lot of ways, it has a lot of the features that you're talking about already. I think that's why some time ago we had actually talked about maybe even having Tim Whalen do a little, just how Salt Lake County is set up, so everybody understands it, because it seems to be a model that's working well. But that's up to the committee.
And I just added that issue of county role and responsibilities. We had a pretty good discussion about even within TAM, the counties still provide a lot of support for those individuals beyond the Medicaid benefit. And there are a lot of dollars that flow through our office, substance abuse block grant, state opioid response grant, opioid litigation funds to come, state general fund, justice funding, drug court funding, that the counties use to provide critical services that are outside of what's reimbursable within Medicaid. And that's why I think this is so difficult to unwind, is if those are things that this population absolutely needs that go beyond Medicaid. So I think as we approach any model, whether it's through contract or even through legislation, defining the county role and responsibilities is really, really important. Right now, it's not a policy decision that we could make to just shift that money over to somebody else. The statute directs all of the money that flows through my office to be allocated to the counties on formula for specific purposes. And so, if we want to change that, that would have to be through legislation. I'm not sure that we do. I'm just saying that as you think about this and conceptualize it, that role that the counties play for this population outside of the Medicaid benefit is really, really important. So, Emma?
Yeah, I think what would be helpful at some point in this process, and I know we've been through some of this before, but is to really identify specifically what those other services are, and so that everyone understands, because there's a fair amount of additional service that the counties also provide by using I'll just use the term buffer that's essentially built into their capitation rates from the Medicaid side as well. And so I think it gets really blurry at some point in terms of what funds the counties are using for what purposes. And so I think it would be helpful just to try to identify what are these other critical services and what is the funding, how are those really funded, so we don't lose track of those.
Yeah.
And Salt Lake County is the only county that, right, well, I shouldn't say is the only county, is the biggest county that is a network model, but we have talked about that if we do this for TAM, we probably ought to do something consistent, at least across the Wasatch Front. And so that raises some interesting issues as well.
Yeah, and it's not even just, I think another issue that we discussed briefly, but I've been thinking about since our last meeting, in terms of that role the counties play. On the substance use disorder side, there's still about 40 to 50% of the population that is not Medicaid eligible that they serve. So who are they? And it used to be they were individuals who were indigent primarily, but not eligible for Medicaid. I'm not sure that's the case anymore. And my guess is many of them are people who are underinsured or have access to commercial insurance or are working, but don't have, they can't access services through that benefit in a meaningful way. And so there's a significant number of people who are being served in that system. And if we disrupt the county system, who's going to take responsibility for that population? That to me is one of the most difficult problems to solve. Where do people who just miss Medicaid eligibility, who are working, who have a high deductible commercial insurance plan, who's going to take responsibility for them? Because that's a critical part of the services that are delivered today. So I don't see any other hands. Other thoughts or comments? Okay, Jen.
Great. Thank you, Brent. And thank you, sub-working group members who contributed to the RFI model. So what we'd like to do for next steps would be to get your recommendation. So we've taken the time to spend, actually significant time, to go through the population, understand utilization metrics, services that are being delivered, some of our desired outcomes. We've been able to identify 3 different areas where we feel integrated models could be of benefit, and those 3 ideas were reviewed with you today after the work of the sub-work groups who've assembled the different framework. And what we'd like to have you do now is give your vote on a recommended model that you would like us to look at. And what we'll do after today is take back your recommendations on either model A, B, or C as they're outlined here on our agenda. So A being the ACO model, B being the fee-for-service and case management model, and C being the RFI integrated plan model. And we'd like to look at it. Please understand that we do have to review these through the lens of both our state authority as well as our CMS regulations in order to create any sort of policy recommendations and model that we would go forth. But we would like to be able to take that back. I also wanted to clarify another point is as the department is reviewing the recommendations that are put forth and designing our final approach that we'd like to make. The deadline for July of next year was that we would have defined a model by that time. I don't believe at this point that the goal, and Representative Dunnigan, I believe the bill language actually stated that we would have a recommendation in place by July of next year, not that we would have a model in place by July. So I just want to know that we have worked at an aggressive schedule, meeting with you at a frequency of even every other week as needed to really try to have robust conversation and really gather excellent ideas about what's best for this population. But our goals really would be, if we aren't hitting a goal of implementation by next July, we absolutely, one of our objectives is to have a recommendation in place by next July. One important piece we'd like you to do as you're voting, and each of you who are official working group members are able to cast a vote on what you would like to recommend going forward, is also this nuance of geography. So while we have 3 different options that were presented, we also would like you to weigh in on our different areas, knowing that perhaps there may be one area, such as a urban versus rural is how we'll break this down. And it was kind of broken down in the framework that we looked at, that you may want to say, my vote for Jen is that A would work in the this area, but C would work in this area. So I'd like you to please contribute as you are putting in your recommendation and voting in that way, that you could also put in if there is an urban or rural or statewide designation for your approach. So if you could, I think one of the ways it may be most easy for us to collect your vote would be to actually put it into the chat. We hadn't worked this out beforehand, but as I'm thinking through it here in our meeting, if you could into the chat, if you would be willing to submit your vote via the chat and then designate it either by recommendation A, you can also state out as the ACO model, recommendation B, fee-for-service case management, recommendation C, RFI integrated plan, and the geography by which you would recommend implementing that, please. Knowing that, of course, you may do too if you're splitting regions. So if you could please do that now. Jed.
Yeah, I would really like some time to go over these 3 different presentations and discuss with our administration before I cast a vote. Just wanted to know if that's an option.
Sure. That's an acceptable option, certainly, Jed.
And then to whom would you like me to send that information?
Yes, if you could send that. Sharon Steigerwald has been sending out the invites on this and has been keeping track of the meeting minutes and all of our documents. And this would, and she's put her information in the chat. If you could share that with her, she can circulate that among our team.
Perfect. I appreciate that. That should be out early next week.
Yeah. And we also recognize that, this time may have not been ideal for all working group members. So I think if we could hear back in a week, does a week seem like an adequate time frame for you? If you don't want to respond today, that we could send it out. And if you want to send your vote, that would be fine too, if you don't want to do it right here. So
Thank
Jennifer, I got your message there, and that's fine. If we could hear back within a week next Friday, that would be when we'd like to have your vote, and we can send an email out to the working group as well. Yeah. Adam, did you have a comment?
Yeah, I just wanted to not ignore what Nina brought up and was talked about with Brent and all of that. That I'd be really curious what the plans are for the ACO. We've been talking a lot about things that are maybe non-negotiable for us, but I'd be curious on what the plan is. That would make my voting a lot easier.
Mm-hmm. Is there any discussion on that from the ACO, Pat?
Yeah, Jen, I think that's really a good point. And maybe what we should do is this: maybe we should try to have a meeting with the ACOs, with the group, with the 413 committee group here, and maybe give them a little bit of a heads up on what we'd like to talk about, just to see where they are. Because I think Adam is exactly right. We do need to hear from them on this, because they're going to be a key partner in this. And maybe what we do is we have a meeting. Maybe that could be next Friday, and then maybe the drop dead date for voting, Jen, could be the Friday after. That would be the 30th, I think. I don't know if that's compressing the time too much.
Yeah. I mean, honestly, Pat, I think we want to make sure that you are comfortable with what your recommendation is, and you feel like you have an understanding of what it is you are sort of voting on. So I'm comfortable with that timeline of being next week. You'd like to meet with the ACOs with the following week, the 30th. Representative Donegan, I don't know if you have other views, but.
So Jen, I need to have a meeting with the ACOs. I met with the providers a couple of weeks ago, and I need to touch base with you. And then we need to have a meeting with the ACOs. I think that's fine, but you and I need to talk and then
Yeah, that's
decide.
great. So, Pat, to your point, I think we can coordinate that meeting so we're present there as well, and we can be part of that conversation. So let me speak with Representative Donegan, and we can communicate a path forward. Nina?
Yeah, I think they do need a little bit of time and a heads up before they come, because one of the things that I would be looking for personally would be some specifics. Sometimes these large companies, they do a lot of boilerplate and a lot of conversations that read in contracting, like will meet all legislative standards from Medicare, Medicaid, blah, 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 blah. And you don't really know what that means. I would want them to have time to really think through specifically what in this state and for this population, what are they going to do? Not just general boilerplate. So they need a little time. So that's.
Yep. And the ACOs are here. Many are represented on the calls. So, yeah. So, and Nelson's chiming in here. That's certainly something I'd like to do as well, to get a little more clarity on what goals and some outcomes, objectives would be. So. Okay, so it sounds as though we need to have at least a meeting with the involved parties here to be able to have a little bit further discussion on some of the elements that would be encompassed in the ACO managed care model, and a little bit more time before the working group members are comfortable submitting their recommended vote on their model. So their vote on their recommended model. Dr. Whittle? Mm-hmm.
Yeah, sorry, Jen. I love exactly where this is going. I agree 100%. I also wanted to point out, I think the lines on these three different options got pretty blurred through the process. I threw into the chat there that subgroup A and C really, instead of diverging, they really converged, and they essentially started saying the same thing. And so it's almost as if we're not really voting A, B, and C. It's really as if there seems to be a convergence of themes in all three discussions that maybe less of a vote, more of a clarification of what those converging elements are, to just bring clarity to the discussion, because there were strong elements in all three that really seemed to need a position at the end of this discussion. At least that was my impression of it. If there's a different read on it, I'd love to hear it.
Go ahead, Pat.
Yeah, Jen, I agree with Dr. Whittle 100% on that. It did get a lot blurry, but there seems to be a general consensus forming now. And I think if we just do an ABC vote, I think we're going to miss something on this. Mm-hmm. So I don't know what to do about it, but I just agree with what he's saying.
Yeah. Okay.
But Jen,
so it sounds like we need to have a little more conversation, which I think it sounds as though I need to connect with Representative Donegan, and then we can reconvene. Again, being sensitive to our working group needs to be an open and public meeting, and this discussion would likely need to occur underneath that. We do have a meeting scheduled for 2 weeks, okay? So let's have that placeholder as one of our standing HB 413 working group meetings at that time, so we can get some of this work done in coordination between our different groups. And I'm comfortable not having a vote today or even in the next 2 weeks. Sounds like we need more dialogue on finding a recommended pathway that we could move forward on, and I'm fine with that. So
Jen, can I have one more thing?
Yes, Pat.
Could we though, and I don't know, maybe we can't do this if we don't have consensus yet, but if this notion that Emma mentioned about the geography of where the model should be applied, is that something that we could actually weigh in on now, or is that premature also?
I think it would be helpful to think about it holistically, right? Okay. As we're looking at the different models that have been presented, and knowing that there's more discussion around what these models might look like. as far as you've had a chance. So what we can actually do is share these notes with the working group members. So I know you've been in these subgroup meetings for some time. We could share some of these documents with you and give you a chance to look through them and contribute a little bit more if needed, or just mull over what was shared in those with those 3 different models. So if that's acceptable, we'll do that. We'll plan on keeping our meeting in 2 weeks, and we'll coordinate together on what that agenda will look like and how we'll proceed there. I know we're just a touch over on time. Are there any other thoughts that we need to discuss at this time? Okay. Well, thank you very much. We appreciate your attendance and work on this important project. So, okay. Have a good day, everyone.
Thank you.
Bye. Thanks.